So welcome everybody to the second lecture of this week on St. Patrick's Day, no less. Unfortunately, I'm not wearing green, but maybe some of you are. You can always show off in the cameras later on. So today's topic is really building on what we were talking about yesterday. So yesterday we discussed different types of healthcare systems, how they work, kind of the ins and outs of some of them. And today we're really zeroing in on Canada's health system. Now, maybe some of you are wondering, what does the healthcare system have to do with geography? Why are we talking about this kind of thing in a health and place, health geography course? Well, it's important to keep in mind that Canada's geography is huge. And so it makes something like healthcare a really, really complicated endeavor. It involves numerous jurisdictions. It involves numerous levels of government. So I think it is a really, really important key part of thinking about healthcare, health outcomes in the context of geography, and why maybe there are some disparities when you take a look across different Canadian provinces. So we'll try to address some of these things in today's lecture. So I want to start off by asking everybody, if you had a question or a concern about your local hospital, which government official would you contact? Who would you get in touch with to talk about something like that, to discuss any issues related to hospitals? So Madison says the mayor. Anybody else? Esme says Minister of Health, maybe. And Esme, which level of government? Because there are in fact multiple ministers of health. Nicole says Regional Health Department. Zoe asks our MPP, so that's Member of Provincial Parliament. Anyone else want to take a guess? I've got one with Municipal. So a whole range of responses here. Anyone else? So again, the question is, if you had a question or a concern about your local hospital, who would you call? Who, in terms of government, which official would you want to get in touch with? So we do have a range of responses here. The correct answer, well, it does depend on what kind of question or concern that you have. So it's a little bit of a trick question. Those of you that guessed any sort of provincial level of government, you are on the right track. So certainly your local representative for the provincial parliament, so your local MPP, that would be potentially someone you would want to get in touch with. But also, if you lived in Ontario, then maybe you'd want to get in touch with your hospital kind of regional organization, which is here in Ontario called a LHIN. It's called a Local Health Integration Network, and we'll revisit that in a little bit later. You might also want to get in touch with your provincial Minister of Health, not federal, provincial. However, if you had a specific complaint that you wanted to file against your local hospital because of maybe some treatment that you had there, some kind of patient outcome that you wanted to raise, then you would actually contact here in Ontario an organization that's called the Patient Ombudsman. Now, the Patient Ombudsman is technically a part of the provincial government, but they are kind of viewed as a neutral agency. They're not really officially affiliated with any politicians from the provincial government, so they try to remain a little bit neutral in that sense, and they explore any complaints that people have against their local hospital that people want to file. Now, again, you would mostly focus your attention around those provincial levels of government. So you wouldn't call up Justin Trudeau, you wouldn't call up your local mayor, you would really focus your attention on potential people in the provincial level that could help you out. Now, what about if you had a question or a concern about a doctor who treated you? Who would you call then? Who would you raise your concern with about a doctor? Anyone want to guess? So Reed says the Board of Physicians and Surgeons. Madison says if it was a major concern, then maybe the police. That's true, depending on whether it was a criminal offense, certainly. Anyone else? Any other guesses coming in? Someone at the provincial level, like the Ontario Medical Association. Okay, interesting. Anybody else? Assuming this says federal government. Madison says College of Physicians and Doctors. Yeah, so I think both you and Reed guessed that one. And so, yes, that is actually correct. Doctors in Canada are technically operating as sort of consultants. So they charge their fees to their kind of provincial health insurance board, but they really are kind of independent contractors that we hire in Canada to provide services related to healthcare. And so they don't actually directly work for the government. So it wouldn't really make sense to file a complaint or file a concern if it was about your doctor to the provincial government or even to the federal government, because there's really not any jurisdiction there. They are a professional association. So although the Ontario Medical Association, which is in charge of kind of their needs as doctors, right? So if doctors had complaints that they wanted to raise to other doctors about maybe standards or practices, then they would raise it with their kind of business lobby almost. That's kind of the equivalent of an Ontario Medical Association. But if it was related to you as a patient and you had a question or concern about something that a doctor did, maybe you'd want to complain about something that a doctor did, then yeah, you would have to actually file that with the College of Physicians and Surgeons in Ontario. So I hope this kind of highlighted just in itself the complexity of healthcare in Canada, and who do you go to when you have an issue or you have a question about some aspect of your healthcare treatments. It clearly differs if you're talking about a system in which you're getting services from somewhere like a hospital versus maybe if you're getting treatment at a walk-in clinic from a doctor. So it's kind of important to keep these things in mind that unfortunately, the provision of care and the provision of different services is a pretty complicated task in a place like Canada. So who actually manages healthcare? Well, since 1867, the provinces are responsible for establishing, maintaining, and managing hospitals, as well as what they used to call asylums, which are now psychiatric hospitals, as well as health charities and charitable institutions. The federal government was responsible for marine hospitals and quarantines, and so they do remain responsible for some kind of unique circumstances. But by and large, it's the provincial government that's really responsible for healthcare. So who paid for it? Well, before World War II, healthcare in Canada was, for the most part, privately delivered and funded. So many people paid out of pocket. Some people had private insurers that they would use to pay, but there was no public system. So why were the provinces put in charge? Wasn't the federal government doing a good enough job before that? Well, taking a look at Canada, remembering that we do live in just such a vast and sparsely populated place, the trick here is that if you were to deliver healthcare at a federal level, it would be really complicated to coordinate different services across such a large geography with such different characteristics in different provinces. So the idea is that if you leave the provinces in charge of healthcare, they'll be able to better manage based on the recognition of needs in their local population, in their local province, and they'll be able to more effectively deliver that care. Now, if you live in a place like Ontario, then it goes even further. And so many provinces actually further regionalize their province, and they make sure that healthcare is managed or services are delivered according to even smaller kind of subunits. So again, in Ontario, that's called the LHIN, the Local Health Integration Network. And these are little subdivisions across the province that effectively manage hospitals that are located within each region, as well as the provisions of some other types of healthcare. So the regionalization of care is a really, really kind of important key aspect of healthcare delivery in Canada. Now, where did our universal healthcare originate? Which province first introduced a province-wide universal hospital care plan? Anyone want to venture a guess? Where did this great idea all start? So Sumnimus is BC, Paulus is Manitoba. Any other guesses? And then Kate says Saskatchewan. Yeah, so for those of you that guessed Saskatchewan, you're correct. So in 1947, Saskatchewan, followed by BC and Alberta in 1950. And then the remaining provinces kind of followed suit after that. What about doctor visits? Any guesses? Which province introduced universal access to doctors? Anyone want to venture a guess? So for anyone thinking maybe Saskatchewan again, yeah, you'd be correct. So Saskatchewan introduced both hospital care as well as doctor visits, the first in Canada, and that was back in 1962. But by the late 60s, 1968, all provinces had followed suit. So by then, all provinces were offering universal hospital care as well as universal access to doctor visits. Now, who paid for all of this? This sounds like a pretty big venture. So originally, the federal government offered to reimburse or cost share about 50% of the provincial and territorial costs associated with hospital services, as well as medical services from doctors outside of hospitals. And the provinces paid for the other half. What's the issue with this kind of cost sharing agreement? Does anyone see any problems that could arise from that? Why might this be a potential issue, sharing the cost 50-50? So Reid says there's a difference in spending between provinces. Namisa says the federal government may not be aware of the population needs in a province. Any other issues that people see with this kind of arrangement? So you've both raised an interesting and kind of similar point. Madison has added, because it might mean that the federal government will have 50% control and they don't necessarily see provincial needs from the same perspective. So yeah, I guess it would also depend on the type of arrangement. Of course, realizing that provinces do, for the most part, have jurisdictions, so they are in charge of what they do with that money. Luckily, the federal government doesn't necessarily put caveats on that, as long as it is used towards healthcare. But I think, yeah, you guys kind of got the idea that a 50% split kind of depends on what that 50% the province is able to offer, right? Not all provinces have the same level of revenue. They don't all have the same number of people who work and contribute to the economy. They don't have the same levels of employment across the province. So it really kind of impacts the pot of money that a so-called province would have to pay for something like healthcare. And so if you're splitting it just right off the bat 50-50, well, that's not really equal. A province that doesn't have as much to begin with will still not be able to gain as much money, even if, let's say, they have a population that requires more complicated types of healthcare. So this introduces some potential issues. Luckily, they did rectify some of these issues. So in the 70s, 1977, the cost sharing arrangement was replaced with a cash transfer and a tax point system. If that sounds complicated, it's because it is. So tax points were basically based on a province's ability to raise revenue. So a province like Ontario and Alberta, let's say, where Usually we had pretty high levels of employment. They were kind of viewed as more economically strong provinces. So from that perspective, we would be awarded fewer tax points if you were living in Alberta or Ontario, and therefore we would be allocated a slightly smaller portion of the pool of money compared to other provinces that maybe had those higher points. Now, the funding formula has since been tweaked numerous times, and currently as it stands, when I was checking this over a couple of weeks ago, the current federal health transfer is only based on a per capita basis. And so this is only as of 2015. So this is pretty recent in the last 5 or so years. It's the amount of money, the amount of cash that the federal government sends to provinces to cover healthcare costs is about based on the population, so per capita. Now, someone else raised that this might be an issue for any specific population needs, and you're totally right. So in fact, provinces are now talking about perhaps needing to tweak this formula again based on provinces who might have particularly high proportions of seniors living in them, right? Because those are provinces that maybe will end up incurring much higher costs towards healthcare because healthcare spending for that kind of level of the population, the older age individuals, does tend to be much more expensive. They require much more care than perhaps what a province with a younger population would need. So I don't think this is the end of sort of tweaking these various funding formulas. Certainly, I think this will be revisited time and time again based on the unique needs that end up coming out of particular provinces. But in general, how much money are we talking about? Again, currently as it stands, we're talking roughly $50 billion that go towards the provinces from federal governments. So this is specifically from federal tax money. Now, what about provincial funding for healthcare? Got a question. Oh, thanks, Regina. Have a good St. Patrick's Day as well.
Yeah, you too.
See ya. So how does a province spend that federal and provincial money? Well, this is a figure from Ontario, and so this would perhaps vary a little bit depending on the province that you're looking at. But once a province receives that money from both the federal pool of money as well as from their own provincial taxes, right, that they've raised. So remember that it is still roughly a 50-50 split. They're not getting all of the money from the federal government. They're getting also some of it from provincially raised revenues from taxes. So once they have that money, what do they do with it? In Ontario, the bulk of it does go towards hospitals. So about a third, just over a third, goes towards hospitals. Another big chunk of it goes towards OHIP, and that is specifically the health insurance program that pays physicians and healthcare practitioners here in Ontario. This would be similar in other provinces, but they do call it something else. So it wouldn't be called OHIP, it would be called whatever the equivalent is in another province. Other proportions do go to community programs, so that might include something like public health programs, other programs like drug programs. So particularly in Ontario, I believe we're still offering drugs or prescription drugs to those under 25, if I'm not mistaken. That has also changed a couple of times in recent years. So that would go towards that, as well as seniors. We also subsidize their prescription medication. And a smaller chunk goes to long-term care homes. Now, this shouldn't be confused with retirement homes. Retirement homes are very different because retirement homes are privately funded. So people pay out of pocket in order to stay at a retirement home. A long-term care home is different in that it's run by the provincial government, or some of them in the GTA are actually run by the municipal level of government, but they use provincial funding in order to run. So again, this is perhaps a little bit complicated, but it does matter in terms of where the money goes and what it can be spent on, or where it should be spent in a given province. So how has the spending actually changed over time? Well, not substantially if you think about it from the perspective of inflation. So the increase here that you see in a place like Ontario has largely been consistent with inflation. We haven't suddenly increased spending radically based on other needs or to reflect other changes. It is mostly due to inflation. But they do say that as we kind of go on into the coming decades, we are probably going to have to spend a little bit more money just because of the population that's growing and aging. And again, that kind of care will require more money to be effectively treated. So where does the federal and provincial governments get this money? As we kind of alluded to, this revenue is based on taxes. And so publicly funded healthcare is financed through revenue that's raised through both the federal as well as the provincial level taxes. So this is tax that you either pay once a year or that you pay anytime you buy something, anytime you get a paycheck, there will be a portion of your tax deducted. Now, those health transfer payments from the federal government do help to ensure that the provinces that are maybe a little bit less prosperous are still able to deliver the same type of care, usually. Now, I say usually because, of course, still, this does vary somewhat based on geography and what governments effectively decide is most needed. So in a public system like ours, when you're really working with a limited amount of money, right, there's only kind of one pot of money to go around and to kind of figure out how best to distribute, provinces and territories do have to make some decisions in terms of how they want to spend it most effectively and what they should be spending that money on. So Powell says, are the health transfer payments part of equalization programs? They're a separate program, but they are kind of similar. So they do have a very similar goal in terms of being able to kind of equalize potential economic disparities, but specifically this is related to health spending. So the reason that it's a separate program is because there is that caveat. The federal government does tell the provinces and the territories that you have to use this money that we're giving you from the health transfer specifically towards healthcare. So that's kind of where it differs. The equalization payments can be used a little bit more generously or liberally in terms of the goals. So as you can imagine, again, when there's this kind of limited pool of money, provinces might decide in their particular province that they should spend it on something like more MRI units. Whereas in other jurisdictions, maybe that's not the priority. Maybe they really want to focus on spending on healthcare access through more health clinics, for example. So that might result, again, in some potential inequalities in what you're able to get in one particular part of Canada. Now, this brings us back to this idea of doctors. So who do doctors work for? I mentioned that here in Canada, doctors are essentially self-employed. Even if they work at a hospital, they are billing the provincial insurance plan provider for what kind of services that they are offering or doing. So we call this a fee-for-service system. And this essentially covers all necessary medical procedures, anything that's been deemed medically required, but also that varies by province. So depending on what province you live in, it can actually affect what type of service you're able to get completely covered. So some provinces do have some discrepancies, particularly around cosmetic procedures. Again, this might impact what kind of healthcare you're able to seek, depending on what province you live in, if you want it to be part of the publicly funded healthcare that you get. Now, does this mean that doctors can bill as many services as they want or that they have time for? Can they essentially make as much money as they want in a healthcare setting like ours? Well, not really, but unfortunately, the system that we have in place can unfortunately create some situations that maybe the healthcare setting wasn't prepared for. So I'm going to tell a quick little story about what happened at a hospital here in Toronto, where I live in North York General. It's actually coincidentally where I was born many years ago. But essentially, hospitals set a strict budget every year based on the amount of money that they get from their government. So in Ontario, it's based on the amount of money that the province gives their particular regional LHIN. Now, the hospital has that set of money. They know exactly how much they have to spend in a given year. And this means that the doctors who are hired to work at that hospital are given a certain amount of hours that they can work, particularly hours that they can spend in an operating room, because that is a service that they charge money for to the hospital that has to get paid out from the province. And so they're given these certain restrictions and limitations for how many hours that they can charge maximum in a number of years. And most doctors, wouldn't pass this limit of hours because it is a pretty high limit depending on the hospital and depending how many doctors work in that hospital. But these are the types of checks and balances that exist in order to keep doctors from maybe having too many patients, being overwhelmed, maybe taking on too many patients that they can actually care for. So it's meant to sort of ensure that doctors only are given a certain amount of patients and can only charge a certain amount of money in the public system in any case. Now, back to this story at North York General Hospital. So for 30 years, Paul Schwen was one of the most respected and really well-regarded obstetricians in Toronto. He was also affiliated with the University of Toronto as part of their teaching staff at the medical school there. And he did some pretty terrible stuff at the hospital in order to try to get more money out of the public system. So what they discovered is that for 30 years, he had been doing some pretty interesting, sneaky services in that he had been inducing labor in pregnant women without their consent and seriously endangering their lives in the meantime, in order to bill the province more money for more deliveries. So nurses were scratching their head wondering, how on earth does this one doctor at the hospital keep getting so many pregnant women, delivering exactly when he's on call, exactly when he's at the hospital ready to kind of serve them? What they found as well is that he tried to make it so that the women were induced and would deliver on weekends because he could charge more money if they were delivered on weekends and he had to work on a weekend. So again, sneaky kind of way of doing things in order to ensure that he would end up profiting from this. What he also ended up doing is that he performed unnecessary procedures like C-sections, again, because the more complicated a procedure is, the more money that a physician can charge. So this is an extreme case of, one bad doctor who did some really terrible, shady things. And I don't at all want to speak poorly of the medical profession as a whole, because I think for the most part, doctors are amazing people. We have nothing but great things to say about them. They really make a lot of sacrifices to deliver great healthcare in Canada. But of course, there are some bad apples among them who maybe take advantage of the system and really just do some terrible things. So I remember being shocked about this when I first read this story a couple of years ago, and I think it really has shaked the medical establishment to the core a little bit. So all healthcare services are universal and publicly available, and there's no private healthcare in Canada. Is this true or false? What do you guys think? Oh, Lamisa asked, did he get punished in any way? Yeah, eventually, after a couple of years that he was investigated, he did get his medical license revoked. I'm not sure what else ended up happening. I don't think he faced any criminal charges. They kind of just wanted to make the issue go away. It was a really, really controversial issue at the time. And so I think they just kind of hoped, well, if we take away his license, he can't do anything anymore. So that'll be kind of a Band-Aid solution after such a terrible, terrible problem that took place. But if anyone wants to read up on this case, I think it was still ongoing as of maybe 6 months ago. So still pretty new. But in any case, do you guys think it's true or false that all healthcare services are universal and publicly available? So Reed and Esme say false. Anissa says false. Does anyone think it's true? Yeah, so it does depend. Remember that healthcare services do technically include a vast number of different services. We're not purely talking about doctors and hospitals. Healthcare services could also include something like dental or eye care. So under that definition, certainly healthcare services are not all publicly funded because we know that we rely on private insurers to deliver things like dental and other. But also, some provinces do offer some private hospital care. So not only places like dentists, but also some hospitals. And so we'll get into a little bit of the nitty-gritty with that, because that is also a very complicated and contentious issue in Canada. So you don't have to memorize a slide like this at all, but I just want to allude to some of this complexity taking place in the background. So different levels of government and other players are involved in the design of healthcare as well as the delivery of healthcare. And this does vary a little bit from province to province, depending on how a province has organized their kind of healthcare system. Sometimes it's based on a regional system like ours, as well as some other provinces, other times no. But what I think is important to discuss is that the levels of healthcare, so if you think about it from different layers, public services for hospitals and physicians, for example, layer 2 being these other types of services that are sometimes publicly covered, sometimes privately covered. So taking, for example, long-term care, remember we said that there were some long-term care homes that are provincially covered and some of those retirement homes that are not, those are privately funded. And then layer 3 is stuff that's pretty much always privately funded. So things like dental care and vision care. Now, these all have different funding streams. So it is important to remember that when we talk about the public healthcare system in Canada, that really only covers hospitals and physicians and medically necessary diagnostic tests. Anything else really does come from either private insurance or from out-of-pocket payments. So there is some differentiation there. So who isn't covered for that layer 2 and 3 stuff? So things like dental, things like eye care, for example. Well, in recent surveys, 65% of Canadians had some private supplemental health insurance, mostly through their employers. So the vast majority of Canadians do have access to those types of services. Another 11% of Canadians had access to them due to federal government-sponsored insurance plans, and we'll talk about that next. The remaining 24% of Canadians paid out of pocket. So who were the Canadians that were predominantly in that 24%? Many of them are newer Canadians. So you can kind of see that illustrated here in the figure, that the proportion with access to dental insurance is significantly lower among immigrant populations, particularly among youth, but also adults as well. So why is this? Well, newcomers coming into Canada do just tend to have a harder time securing a job that would be full-time and that offers benefits. So unless you have a job like that, that gives you access to those types of services, you're probably going to have to pay out of pocket unless you're able to access some other types of subsidized programming that I know does exist in some jurisdictions like Toronto and other cities that do help. Now, this is predominantly covered by provinces, right? So places like hospitals, places like doctors, they are covered within the provincial jurisdiction. You can't use your OHIP, for example, to necessarily go get care in another province. Usually you'll have to go through a system of reimbursements, and that's a whole other can of worms that we won't really get into today. But so who are the 11% of Canadians who have access through federal government-sponsored insurance plans? Well, it's a bit of a VIP group of Canadians. So they are Canadian forces, they are inmates of federal prisons. They're also eligible Indigenous people, so specifically those living on reserves or those Inuits living in traditional territories. They also include veterans, as well as some refugees sponsored by the federal government. So it's not a big proportion of Canadians, but they are some, they do exist. And so these people are covered not by something like OHIP, but through a separate kind of pool of money. Now, additionally, employers do pay for medical treatments that are required for workplace injuries, and that takes place through provincial workplace compensation boards. And that, again, is a whole other complicated system that we'll touch a little bit on at the very end of the term when we talk about workplace and health. So that will not come up again in today's lecture. Now, maybe you're wondering, what else does the federal government do? Are they just providing money? Is that really their only role? Do they only provide care for that limited sort of 11% of Canadians? Well, no, they do take a part in other aspects of healthcare for Canada. So for example, they do fund a lot of research that takes place. So they're not just funding directly hospitals, but they often do subsidize research, particularly if you're thinking about something like a CIHR grant. If any of you are considering grad school in the future, then that is a federal scholarship that essentially does pay for a lot of really great health research that goes on in Canada. Now, the feds are also responsible for something like food regulation as well as pharmaceutical regulation. So they do set really, really important standards around things like that that would impact all Canadians. Of course, we mentioned that they do take part in the delivery of healthcare for First Nations and Inuits. And also, they do administer some really important guidelines for the country as a whole to use. So for example, the Canadian Drinking Water Quality Guidelines do set standards nationally that provinces can then take even steps further in order to ensure access to quality drinking water for Canadians. Now, some of you mentioned municipal levels of government, for example, mayors. So what kind of role might municipal governments play in this very complicated patchwork of healthcare delivery? Well, again, it depends on your province. So in Ontario, public health services operate mostly at municipal and regional scales. If you've at all been paying attention to the pandemic, maybe you hear talk about your public health unit, maybe you've heard about your medical officer of health. And that is really a unique situation in Ontario because of the way that public health was set up, a long, long time ago. In other provinces, it is scaled up, so more public health takes place at a provincial level instead of at the municipal level. But in any case, here in Ontario, municipal and regional scales of government do take control over delivering public health services such as vaccinations, also STI testing and any sort of infectious disease prevention and diagnosis. They're also responsible for something like paramedic services, as well as delivering care in some long-term care settings, particularly mostly in the GTA. I'm not actually aware of other municipalities in Ontario that do that. In other provinces, these services are, again, mostly delivered at regional health authorities or sometimes just at the larger provincial scale. So that's kind of the difference there related to municipal governments. Now, which provinces allow private care? Well, like most things that we've been talking about today, even that question is a little bit complicated. So depending on your province, in Alberta, Saskatchewan, New Brunswick, Quebec, and PEI, they allow doctors to bill patients directly, which means that a doctor can actually get paid from a patient's private insurer or from out of pocket. But this is only if they opt out of the public healthcare system. Why is that? Well, provinces don't necessarily want doctors to be able to see a patient in the public healthcare setting, refer the patient to their own private healthcare clinic, and then be able to treat the same patient twice and kind of double dip in the pool of money. So that regulation is in place to try and stop some of that and a potential loophole that could exist. So provinces do technically allow doctors to opt out of that public system. But again, if they opt out, then they can't also be paid by the public insurance system, only the private system. And most of these provinces do have strict rules about billing and what they can charge for. And again, this is kind of to ensure that there are some checks and balances that exist to make sure that people don't just visit these private healthcare clinics where they do exist in Canada. So just as an example of some of these kind of wonky rules that are in place, in British Columbia, a patient who requires more than 24 hours of care cannot be treated in a private clinic. Why is this? It's an interesting question. I think they are trying to essentially avoid private clinics from overbilling a patient. So if a patient does require really complex surgery, it sort of forces that patient to be seen in a public healthcare system where a recovery time might be more than that 24 hours. So it is sort of in place to protect the patient, to make sure that they don't suddenly rack up a really exponential bill in a private clinic when maybe it wasn't anticipated for their surgery to be so complex, for example. So that just kind of makes sure that a patient who does go to a private clinic in somewhere like BC wouldn't have such a large bill for that particular procedure. So numerous private health clinics do operate, and there are, in fact, a few private hospitals, and these are scattered throughout the country. Certainly, there's a pretty famous one in Vancouver. There is one in Toronto as well, or sort of north of Toronto, and there are a few others. So now that we are aware of some of these nitty gritty kind of policies and regulations around healthcare delivery in Canada, what are the current healthcare issues and how are they associated to this greater system that we've been discussing? So I think it's no surprise, most people are aware that there are some pretty long wait times for non-urgent care in Canada. This is a problem that I think has been discussed for many decades. There's also nursing shortages. So that's a pretty big issue because it does limit how many procedures can take place in a hospital. For example, if there's not enough nursing staff to assist doctors for procedures. There's also not enough family doctors, particularly in rural regions. And there's not even enough jobs for trained specialists or surgeons in many hospitals around the country. So increasingly the wait time for medical residents who have gone through all of the relevant training, increasingly they are waiting to be able to find and secure a full-time job as a surgeon or a specialist. So just as an example to illustrate this, I found this kind of interesting graph that shows that the nursing positions do vary by province in terms of the demand or want for nurses to be based in those provinces. So in smaller provinces, particularly in places like the Maritimes, the nursing positions typically get less clicks on a typical posting that would be posted for nursing jobs. So there's less people who are interested in even applying to those jobs in many places of Canada compared to, let's say, in Ontario. For whatever reason, Ontario is a very desirable place to live. And so nurses do tend to be more interested to actually try to find a job there. So maybe you're wondering, with all of these issues around staffing and shortages, why can't we just hire more doctors? Wouldn't that even alleviate some of the waiting times for potential surgeries? So enrollment in Canada's 17 medical schools has remained flat over the past several years at about 12,000 students. Now, why is this? Why can't we just train more doctors, hire more doctors? Well, predominantly because there's a shortage of residency spots to actually train those medical grads. So when someone graduates from medical school, they have to land a residency in order to get more specialized training in whatever particular field they want to end up with. So there's a shortage of those spots. In fact, the number of unmatched graduates from medical school has been increasing over time. So, potentially hundreds of students every year in Canada who graduate from medical school are not able to secure a residency right away. Sometimes they have to wait for the next year to be in kind of another round of applications. So that can definitely have impacts. There's also a shortage of jobs for even those residents who have been trained and who have passed their certifications and who are ready to work in a hospital setting on their own. Doctors also move around. So there's really a careful balance that takes place in terms of where you can build a medical school, where you hope to attract medical graduates and really hope that they stay. So in many places, particularly I'm thinking of the rural Northern Ontario Medical School, they really try to push that the people who graduate from a school like that do stay in the community. They don't just leave and then go back to Toronto to go practice medicine there. So why is this? Why can't we just, get around some of these rules? Well, not enough graduates want to enter family medicine because there is less take-home pay. Family doctors do have to pay for things like overhead charges to run their kind of office. They essentially are a small business. And so there are a lot of kind of fees and payments that need to take place. It's also not in the current doctor's best interest to hire more doctors. So in fact, in a place like Ontario, Ontario's Medical Association does not necessarily advocate for more doctors to be hired. Why do you guys think that might be? Why might doctors who are currently in the province taking pay, why might they not want more doctors to be hired and trained? What do you guys think? They lose business essentially. Yeah, less hours for themselves, so less pay. Exactly. Yeah, so at the end of the day, doctors, remember, are kind of working as consultants. And so it's really not in their best interest for there to be suddenly many more doctors, which would affect how much money they can get, because the pool of money or the pot of money coming from the government is not suddenly going to expand if they hire more doctors. And so essentially it would mean having to divide that pool of money amongst more doctors. And so their pay would probably be impacted depending on the number of doctors that could be hired. So what if we add some privately funded care? Would that solve some of these issues that we're talking about? Well, the experiences from other countries suggest that it could introduce some other issues. For example, in Australia, they do have a public and private system. However, it's been found that among those who seek care in public hospitals, for example, the waiting times tend to be significantly longer compared to private clinics. And so this does kind of create a two-tiered system of those who are able to pay get, faster, potentially better healthcare services than those who are not able to pay and who have to be in the public system. So I think that's, the main concern that people do tend to worry about. So what are governments trying to do? Well, one thing that they are actively trying to do is encourage more home care to free up hospital beds, because remember, there's a limited amount of hospital beds in a hospital setting, and that also impacts the number of procedures or operations that can take place. So home care just means that after a patient feels well enough to go home, they do tend to be discharged pretty quickly in order to sort of get the ball rolling and make sure that they can be taken care of from the comfort of their own home, particularly if they're a low risk patient with very low risk of complications, then that could potentially free up more beds in the hospital to treat more people. There's also been pushes recently for e-health. So to really take off the burden of some of that admin work that goes on in family doctors' offices, many of those offices are still using fax machines. So I think there's going to be really a push in the coming years to try to get everything online. There's also, as we talked about, some incentives to medical grads or doctors to stay based in rural and remote regions to address some of the shortages in medical staff there. What else could be done? Well, there's been talk of potentially adjusting the current physician pay system, but who knows where that will end up. It might not be a very fruitful discussion to have, because I think doctors are overwhelmingly not in support of it. There's, of course, recruiting and hiring more nurses. That would certainly address some of the shortages there, and also potentially offering some services privately. But it should be noted that by and large, most Canadians do not support this. In fact, in most surveys that come out around this kind of stuff, anytime a Canadian is asked whether it would be fine if you could support private healthcare if people who couldn't afford to pay would potentially wait longer services, by and large, people do not support that. I think Canadians are very proud of their public healthcare system. And so anytime you try to have a discussion around potentially privatized healthcare, it does tend to get a little bit messy and controversial. So Lamisa says, is there a growing demand for physician assistants now in Canada? Yes. In fact, we do have some categories of nurses who are able to administer more complicated types of healthcare, particularly in rural and remote areas of provinces. And that's a topic that we'll get to next week when we talk about access to healthcare, and particularly the lecture around rural and remote health. So stay tuned for that. Okay. Now I want to end this lecture today with just a couple of thoughts about medical tourism. So would you guys travel outside of Canada to access healthcare for a faster process somewhere else? Would you travel to go get quicker healthcare? What are your thoughts? So Sarah says if it was urgent, then yes. Lamisa agrees if it was for an urgent issue. Anyone else have an opinion they want to share? Would you travel outside of Canada to access healthcare? Reed says if I could afford it, sure. Yeah, so I think there's two kind of trains of thought here, depending on the urgency as well as depending on the costs. Well, Canadians are doing it. There's no real data to suggest how many are. So this is mostly based on some surveys and some studies that have been done to try to quantify the number of Canadians. But overall, about 2% of Canadians are estimated to have traveled to some other country in order to undergo either a doctor's visit or some kind of medical test or procedure. Some of these common destinations include places like Brazil, India, and among others, but also even within Canada. So traveling to another province is not that uncommon. And so what are people having done? Well, the most common procedures are orthopedic, neurosurgery, things like liposuction, cosmetic, plastic surgery, as well as others. And so it does vary, I guess, depending on the needs. Someone mentioned level of urgency, and so that might also kind of potentially play into and factor into people's decisions, certainly around potential cancer treatments. We're talking about oncology, so that might impact it. So I want to end with a little bit of food for thought today. There has been talk, I think, in the recent months about potentially exploring more private care options during the pandemic because there is a huge backlog of elective surgeries that haven't been able to take place in public hospitals during this pandemic because of many canceled procedures. So I guess based on what you now know about Canadians' public healthcare system, maybe it's something worth thinking about on your own and what role private healthcare could play in a place like Canada, where we've by and large decided not to include it, certainly not in any formal capacity. So I'll stop the lecture there.